I'm not Mark Ripe. I'm Deepa Halaharvi.
I am Mark Knight. I'm
There
glad
you
you're
go.
not. That's
Yeah.
great.
All right. So I will be starting with screening guidelines for breast cancer. These guidelines change a lot. So let's talk about what guidelines we want you to follow, what guidelines we follow as breast surgeons. I'm also going to talk about screening for dense breast tissue.
I'm going to talk about the high risk patient. How do we define those patients? And then what do we do with those patients to prevent breast cancer?
So breast screening, this is a confusing topic. And as you see here, there's different guidelines. There is the USPSTF guidelines, the ACP, the ACS, the ASBRS, the ACR, NCCN. They all have different ages where they start recommending getting a screening mammography. Some are every year, some are every 2 years. And also there is no consensus in when to stop getting screening mammograms. So we keep it very simple here where we work in Columbus, Ohio. We follow the NCCN guidelines, and we recommend an average risk woman getting annual mammography at age 40.
And this also changes. So the USPFTF used to be 50.
Correct.
It's gone to 40. My guess is also the ACP is going to change as well.
Yes.
So it's a forever moving target. So here's the different kind of guidelines. And I know for primary care, you have to use USPFTF for your board certification. So you want to know what that says, even though when you're out in practice, it might be different.
Yeah,
so
that's
just,
a good point.
I think understanding what does the American College of Radiology say, and then also our national cancer screening guidelines, that's what we're going to follow.
This is very confusing for us as clinicians, but can you imagine the confusion that happens with patients? So what do we say? So we say to start your annual screening mammography for that average risk. That is the key, is the average risk. Dr. Kripe will be talking about high-risk patients. These are the patients, their average risk, and we say average risk for developing breast cancer is anywhere from 12 to 13% lifetime of developing breast cancer. We say 1 in 8 women will get diagnosed with breast cancer. Why screening mammography? Well, this screening modality has been studied in well over 8 randomized control studies, which has shown a mortality reduction up to 30%. It also allows us to detect cancer at early stages, which means less invasive treatments. And also studies have shown with the screening mammography, there's least life years lost. So let's talk about breast density, and it really does apply why mammography does that impact the type of density you have in your breasts. Well, when we look at the sensitivity of a mammography, it can vary anywhere from up to 70% in extremely dense breast tissue to about 93% in fatty replaced breast tissue. And let's look at the picture of what looks like a fatty breast to extremely dense. As you see on your left, it's a fatty breast. As you see, if there is a cancer which looks white on a mammogram, it would be very easy to see. If you go all the way to the right, where is extremely dense breast tissue, it's easy for a cancer to be hiding in that whiteness of the density. So the sensitivity does depend on the density of your breast. So for those women who have extremely dense breast tissue, there is lower sensitivity. Now, in this world, nothing is 100%, right? Like, so screening mammography, it can miss up to 10 to 15% of cancers, whether it's maybe because how the mammography was performed or just the density of the breast. So it's important to know that just because a mammogram is negative and the person is still feeling a mass, we still want to investigate that. And there is intermediate or moderate risk, which goes between 15 to 20%, and elevated lifetime risk of developing breast cancer. Dr. Kripe will talk about it, but there is what's called supplemental screening, and that would apply to all these people. And also sometimes patients just come in and wanting supplemental screening. So what is the problem with that? Well, I mean, what is the good thing about supplemental screening? Well, it can increase cancer detection, which is great. But, like we always talk about, we don't want to order a test if you're not going to do anything about it. So if you're getting an ultrasound or an MRI, what are you going to do with it? And how are you going to apply it? What age is the patient? Is the patient at age 80 who's not going to do anything with this information? Or the patient, wants to do something if the biopsy comes back as cancer? So cost is something we constantly want to think about as well. So supplemental screening is now covered by insurance by this Ohio House Bill 371. It went into effect in September of 2022. And what this is basically, it would require health insurance companies to cover for MRI or ultrasound screenings for patients with dense breast tissue or family history of breast cancer.
And I'll interject a little bit also. Once you get out and start ordering these tests, the patient now gets on their phone right when it's done,
Yes.
even before you get it, but they typically would get sent a letter. I think they'll probably be changing. At the bottom, it says you have dense breast tissue. Mammography may not be, I don't know if it says as good, but may not be the most appropriate test
Yes.
for you. So the patient gets this and they say, oh my gosh, mammography is not good for me. What do I do? And they call you.
Yeah.
And that's why we're trying to go through this, because whoever orders a test, so it's going to be GYN or family practice, you get the phone call from the patient and like, what do I do now that my mammogram is not good? And it's not true, but again, that's what the patient interprets. And so that's why it says you could consider additional screening. And then like, okay, what is that? So that's why we're trying to educate. There are a number of different supplemental screening. The ones that we have currently at our institution would be MRI, so abbreviated MRI or the ultrasound. There's other ones. It will be changing, but just to know, then the patient say, well, is it going to cost more? And again, screening different than I feel a mass, which is called, then they need diagnostic workup of a problem. This is for the patient with no problems.
That's a great point. Thank you. Supplemental screening in Columbus, Ohio, where we practice, the two modalities that are available are screening breast ultrasound and abbreviated breast MRI. Well, let's talk about each one of them and who this could be best applied in. So for patients who have dense breast tissue, and when we talk about dense breast, those are the categories that go from A to D, is the C and D categories. That's who this applies to.
And we talk about it, dense breast being on imaging dense breast versus someone that does an exam and that feels like a cement breast. That's a dense exam or a challenging exam, but not dense breast. So again, patients get confused many times with that.
Yeah, that is correct. And it's important to identify the dense breast on physical exam and you will be getting physical exam experience when you come to work with us in the office. And so an ultrasound, it's known to detect about 3 cancers per 1,000 cancers. And it does reduce interval cancers. What does that mean? So from mammography to mammography is 1 year time. And if you're getting an ultrasound in between those times, it can potentially detect cancer in between those times. It could also potentially decrease late stage cancer or diagnosis of late stage cancers. But the thing about ultrasound that's different than a mammogram, what I said earlier, mammogram has really been well studied in what we call the gold standard studies, randomized control studies, which are shown to decrease mortality. But ultrasound has not been studied in that fashion, or we don't know a mortality reduction for ultrasound. There are more false positives with that. And why is that? Because it's really a technician-dependent modality. And studies have shown women do end up having more biopsies and additional follow-up exams.
So when they get an ultrasound, then does that replace the mammography?
That's a great question. It does not replace the mammography. And it's really important, women will say, oh, the ultrasound was so much easier than a mammogram. The gold standard is still mammography, yearly mammogram, not thermography, mammography. So then who would you get a screening breast ultrasound on? Average risk with dense breast tissue. So I said average risk of developing breast cancer is 12 to 13%. And those women, if they have dense breast tissue, they're candidates for this. Intermediate risk or moderate risk, what we call between 15 to 20% lifetime of developing breast cancer, can get an ultrasound. Now, high-risk women, absolutely, you can get an ultrasound, but they also qualify for MRI, and really depends on where they are at their age. And again, like Dr. Kripe was making a point, it does not replace your annual screening mammography. The next thing I'm going to talk about is an abbreviated MRI. And this actually implements the full breast MRI protocol. And you could use it for average risk or moderate risk patients. If someone has high risk of breast cancer, greater than 20% lifetime risk of developing breast cancer, they really need to get a full MRI protocol. But the abbreviated MRI is for those patients who have dense breast tissue, whether they're moderate risk or average risk. The difference is it takes less time to get an MRI. The traditional MRI takes about an hour. This takes about 10 to 15 minutes. It is lower cost. I want to say it's about like around $350, but insurance should cover it based on this 371 bill. And the good thing about this modality for the patients and the patients, less time for the radiologist, it's easier, less time to read it. But also, in my experience, patients who have had an abnormal abbreviated MRI, they went on to get a traditional MRI.
Right.
Have you had the
I
same thing?
agree.
Yeah. So then let's talk about so why is this beneficial? Again, it's less sequences. It only takes 15 to 20 minutes to do the abbreviated MRI. It still catches cancer just as much as a traditional MRI, which is about 12 to 15 cancers per thousand. So the cancer detection is still about the same.
And that's in addition to mammography. So
In addition to
yeah,
mammography.
so when we talk about these couple additional cancers, it's in addition to the mammography. You're
That
going
is
to find
correct.
more cancers, but they still need an IV. So when you talk about contrast, I still warn patients, you're going to go in probably head first. You lay on your stomach, the breast one of these cones, but they get an IV and they get contrast. So a number of people say, I didn't know I was getting an IV. I just thought I was coming for an X-ray. For this, there is enhancement that we're looking for. So they get contrast, so they get an IV.
Yeah, they get the gadolinium. And yep, that's a good point on mine. I want to give credit to Dr. Lauren Miller. She created this algorithm. She was one of our radiologists who worked here in Columbus, Ohio previously. And so, okay, so you have a patient who comes in and their average risk for breast cancer, and they have non-dense breast tissue. So this is what we're looking at. So for these people, you do not need supplemental screening. But you have a patient who comes in at average risk, but they have dense breast tissue. You obviously can get them a screening breast ultrasound. And again, average risk is, 12, 13% lifetime risk of developing breast cancer. You can also get abbreviated MRI for those patients. But if they're intermediate risk, whether it's 15 to 20% or moderate risk, you could get a screening breast ultrasound. You could also get an abbreviated MRI in those patients. The important take home from this algorithm is to know that the high risk patients should not be getting the abbreviated MRI. They really need to get the full protocol MRI with and without contrast.
And again, this is probably the take home point for you all when you get out in practice and the patient's, okay, I got my mammogram and it says it's not as good. What do I do? This is probably the one screen, knowing it's probably going to change as we get other modalities, but I think this is great. The only thing I would probably add is say this is in addition to screening mammography, because some patients think, okay, I'm not going to get a mammogram because it's not as good for me. It's still going to see calcifications and other things that would not be identified on MR and ultrasound, things like atypical or high risk lesions.
Yep. All right.
All right, high risk. So what in the world we talk about high risk? We've been talking about supplemental screening. What's high risk? What's average risk? So this is an individual who is at risk of developing breast cancer, but's not yet had the disease. So this would be patients that have a genetic mutation. They may know or may not know they have a mutation. They've got family history of breast cancers and then other different risk factors. And we talk about who's at high risk. They come and say, oh, I'm at high risk because mom had breast cancer. They come and say, oh, I'm at high risk because grandma had breast cancer. I love this one. Oh, my neighbor had it. So then we do actually see patients that live in a neighborhood that probably have some other environmental factors, but that's kind of a joke. So now really it's looking at what's my risk. Nobody knows what your risk is, but totally looking into the future. We don't have a crystal ball. Even if you're at high risk of, let's say 20% lifetime, that means 80% chance you're not going to get breast cancer. So what are risk factors? So when you start to quantify risk, you have to understand first, what is a risk factor? You guys are the gatekeepers. You're the ones that are seeing all of these normal, average, don't have a problem patients. And you are the gatekeeper to need to know who then is at high risk. So here are all the different risk factors. I'm not going to read all of them off. I'm going to kind of point out a couple of them. Radiation exposure to the chest or mediastinum is a big deal when they're under the age of 30. And we kind of forget that. So it might be your 60-year-old or 70-year-old patient that had lymphoma when they was a kid, and they just put on there, oh yeah, I had lymphoma. In the old days with lymphoma, sometimes they did big surgeries, but sometimes they radiated the mediastinum, and so that would get the breasts, and they're really high risk of developing a breast cancer and would benefit from additional screening. So that's a big one that I think that I miss, or we often, probably most of us miss. people that have a genetic mutation, first-degree relatives, that makes sense. Again, looking at other risk factors, these are more the moderate or minor risk factors, but things that we also need to talk to patients. And what I kind of jokingly do is I have every single resident calculate your risk. In med school, we're all going out and having parties and celebrating, we're drinking alcohol. We sit around and we don't do anything because we're residents and we're overweight many times, sedentary lifestyle, hopefully not smoking. But you could have some family history, and then people are delaying pregnancies until after the age of 30 because you want to get out of residency and get your job. And so there's a number of us as providers that are actually at high risk and we don't know it. So trying to quantify that then. So first you have to know what the risk factors are. If you don't know what the risk factor is, you can't calculate the risk. So knowing the risk factors and then identifying those patients at high risk, because the goal of for us, for it should be for all of us, is we want to prevent disease. I just tell people we can treat disease. We're really good at treating cancer, but man, if I could prevent cancer, that'd be awesome. And then we want to find it early if they do get a breast cancer.
I do have a question for you.
Yeah.
So what about the woman who's going through menopause and wants to get hormone replacement therapy? How would you counsel that patient?
Yeah. So those are the big thing. We're seeing a push. So right around the early 2000s, hormones bad. And
Right.
everybody kind of went up. We saw a dip of the incidence of breast cancer. So whether you talk about the Women's Health Initiative, you talk about the Nurses Health Study, you talk about all these different initiatives, like, okay, they're all fraught with challenges. But if you just look at the incidence of breast cancer, when we decreased combination HRT, it went down. So whatever you say about the study, the incidence went down. For women then that say, I'm miserable, I can't sleep, I have vaginal dryness, I mean, mental fog, and have no family history of breast cancer, don't really have many risk factors, then I think very appropriate to put them on systemic hormone replacement therapy, understanding there's going to be a slight increased risk of developing a breast cancer. For those patients, I'd definitely say make sure you're getting your imaging annually and coming in. So I wouldn't be prescribing that if they're not getting their imaging.
Yeah.
And also, if they have more of a complaint of vaginal dryness, frequent urinary tract infections, pain with intercourse, you don't need to give them a pill or a cream that's going to go systemically. You can just do a vaginal estrogen, and that the first month when you do a vaginal estrogen, you're going to see a spike of a little bit of estrogen. And then if they're using it appropriately, it goes down and is undetectable systemically. So patients that are just having pain with intercourse, loss of libido, frequent urinary tract infections, I think doing a vaginal estrogen, I'm completely fine with. Even sometimes for those breast cancer patients, if they're using it appropriately. A lot of patients say, I only use it when I need it. Well, that's wrong, because you actually need to build up the lining of the vagina so you're not getting that systemic absorption. So they really have to take it as prescribed.
Yeah, what I was going to say is I think as breast surgeons, I mean, I'm for sure I have a bias because when I sometimes see women who've been on hormone replacement therapy 10, 20, 30 years, and I think it's really important to let them know you don't need to be on it for that long. If you're going to be on it, short time until your symptoms are better, or find out what the symptoms are. There's so many things we can do to treat the symptoms, hot flashes, night sweats, like you talked about, the vaginal dryness, pain with intercourse. We still want women to have good quality of life, but it's important for us to educate them.
Yeah, I had a lady that's 75 and she comes in and she's on hormones. I'm like, why? And she's like, well, I had problems sleeping when I was 50. So I'm like, okay, it just in my simple brain, every probably 2 years or so, try to decrease the dose, find the minimum dose, and then see if you can get off. Because if you're just on it for 25 years and you don't know why you're taking it anymore, like we need to get off those medications when we're beyond the side effects.
That's a great point.
Great.
Thank you for going into that.
Yeah. Goals of risk assessment. You have to identify what's the patient's goals and what are our goals. So our goals as clinicians, we want to identify the high-risk women, not just so that they're scared. We want to identify it so we can prevent it, do risk reduction, and then early detection. Those are our goals. We call those, I think of them as a previvor, meaning they haven't had cancer yet, but they're at risk. They're going to get cancer. That's a previvor. Again, identify those. It does mean, though, you're going to see more doctors. You're going to have increased screening. You're going to have increased potentially anxiety about developing cancer. There's some cost associated with it that it's not insignificant cost either. And so we need to make sure to talk about that with our patients. And some people say, oh my gosh, I have the feeling of the inevitable. I've got some ticking time bombs and they're going to blow up and just it's a matter of when rather than if. And that's not true for everyone. So really, again, how do we quantify high risk? There's different risk assessment models. So we need to know what are the risk factors. And then these different calculators will take different risk factors and put it into this risk assessment and come out with their specific lifetime risk of developing breast cancer. They do often a 5-year, some do a 10-year. From an insurance standpoint, from getting MRIs covered, et cetera, really we look at a lifetime risk of developing breast cancer higher than 20%. So that is considered high risk. Like Dr. Harvey was talking about for the dense breast that have a moderate risk, so somewhere around a 15 to 19% lifetime, those patients may undergo the abbreviated MR versus the whole MR. Once they get the 20% or higher, then they get the full MRI, which means 5 different sequences of MRI. So again, that 45 minutes, and they're going to get looking at better enhancement of the contrast. So this is a patient that had the Gale risk model. And so when you type it in and we put on there how to find the Gale risk, there's a number of different companies that want you to come to their website to calculate risk. I like to go to the actual Gale risk assessment, which is the .gov. So the breast cancer risk tool .gov. And then this is going to be kind of what they're looking at here. When you get the screen, they'll talk about the average risk patient for that age versus the high risk patient. So it's very, I think, self-explanatory. What they're looking at, though, is going to be age, race, again, atypia, age at first pregnancy, and first-degree relatives. So if you have someone that only has, let's say, the risk is through dad's side of the family, they may not have any first-degree relatives, they're all second-degree relatives, Gale is going to miss that patient. So the Tyrer-Cuzick, it's a little more in-depth of a risk assessment model. Still, I think you can calculate it pretty quickly. It's got a weird website. Patients always kind of go through this and like, oh my gosh, or I mean, it's not patients, well, could be patients too, but our learners, like, I couldn't find this Tyrer-Cuzick. Well, it's called IBIS, which is kind of funny, and it has this Egyptian sign of life on there. That's okay. That's what the real website is. And it's looking at a lot more factors that would go into risk assessment. This includes breast density, Ashkenazi, Jewish ancestry. It talks about some males, and you can also, instead of putting in just who's positive or had the cancer, you can in pertinent negatives, and it calculates a whole pedigree. So it's a lot better risk assessment tool. And I encourage all of you guys, when you're a learner, although you feel the weight of I got to study for boards, I got to study for in-service, I got to study for this rotation, I got to take care of my own clinic patients, you have the most time with every patient right now than you'll ever have in your entire life. Like, you're not getting a fee for service, you're not getting all these things, you don't need to see a patient every 15 minutes, or 10 minutes. And so take the time now to get familiar with the risk assessment models. So then when you're out in practice, you already know it and you understand it. And I have these risk assessment models up on my computer all the time. So it's just, you start clicking and it becomes pretty easy once you're familiar. Why different screening recommendations, why different things we can do, a lot of options. And again, I always talk about, we have our goals. I want to prevent cancer. I want to find cancer when it's early. A patient may not have that goal. A patient may say, I don't want to know anything. It freaks me out. I'm so scared. I'm just going to put my head in the sand and never go see a doctor. Okay, then let's not do genetic testing. Let's not do MRIs, because we might find a little cancer that we can cut out. And if they don't want to know, then you're not going to order some of these tests. So know what that patient's goals are. Some of them say, I don't have any money. One lady came in, had atypical biopsies all the time with her screening mammography. And she walked in, she's like, Doc, will you cut off my breast? Because getting a biopsy might cost $2,500 with her insurance. An MRI was $1,500 with her insurance.
Yeah.
And then you go to surgery. And I mean, my gosh, you can't walk into an operating room for under like $6,000 to $7,000. She's like, every year I meet my deductible of $5,000 every year just for my breast, and I don't even have cancer. Can you please cut them off? It'd be $5,000. And she can get mastectomies and reconstruction. And so again, understanding what is that patient's goal. Again, our screening recommendations for the higher risk women are going to be a little different than the average risk women. So these are screening for average risk women. High risk women, it's going to be still the monthly self breast awareness is technically what we're supposed to say. I'm not always a politically correct guy, so I still tell the patient self breast examination because they understand what an exam is. I don't know that they know what awareness is. Like, you're aware of your breast. To me, that just doesn't make sense when I'm talking to my patient that's just sitting in front of me and like, oh yeah, I'm aware of my breasts. No, self breast exam and know what you're feeling for. A clinical breast exam every 6 months, starting at age 25, if you're high risk. So different than those average risk women. A mammogram would start, typically, we don't start mammography earlier than age 30, kind of for anyone. And you want to start it, again, for average risk at 40, 10 years younger than the youngest person diagnosed with breast cancer. So if grandma had breast cancer at 42, you're going to start mammography at 32. So 10 years younger, not before age 30. And then for patients with a genetic mutation or, again, high risk, greater than 20% lifetime, consider annual MRI not earlier typically than 25. So the BRCA, some of the high risk women, the highest risk women, we don't start MR until 25. Again, or 10 years younger than the earliest person diagnosed with breast cancer. So if identify somebody at high risk by the Tyrer-Cuzick, but all of the cancers start at age 60 and 70, you're not going to start your MR until age 40. You can start it earlier than 40, so 10 years earlier than the youngest person diagnosed. We follow the NCCN guidelines, so this is just a little snippet. Again, these guidelines change. I want all of you to get on and get your own free account of NCCN. A lot of people think, oh, this is just for cancer. Not true. It has a ton of screening recommendations for colorectal, GYN, breast, and all of these keep changing. So learn where to find the information. Everything you learn now, not everything, many things you learn now in residency
Yeah,
will
will
change
change.
with
Yeah.
time. So know where to find the information. And I like the quick PubMed. I like the little fancy things. If you go to NCCN guidelines, that's where we go. Then the other nice thing is if you get a friend that's diagnosed with a different type of cancer, you can find out what the current recommendations are as well. But looking at screening, they have some really nice algorithms, but all of those talk about the average versus high risk patient. So again, if you don't know how to calculate the risk, you kind of miss the whole power of the NCCN guidelines. I would also say once you get this account, the algorithm can be intimidating. Once you get familiar with it, it's not as intimidating. But if you go about halfway down, it's all written out in a paragraph form. That's probably best for you guys to start with, looking at the instance, and it's written out in a paragraph. And then you can also take those references. If you click on it, it takes you to the actual article. So if you have some desire to learn more about screening ultrasound, but you're not sure how to find it, this is a hugely powerful tool to then find the original articles that we all cite on what was practice changing. So a hugely powerful tool. I will have you get on the NCCN guidelines, 100% guarantee. So do it before you come in.
He does. He will.
Yes. How can we change your modifiable risk factors? I'm typically not telling people, all right, hurry up and get pregnant. Yeah, no, we're not going to do that. So, but you do want them to understand for having children before age 30 is going to reduce your risk a little bit. If you breastfeed, that's changing the cycling of your hormones. So that's going to reduce the risk a little bit. For the BRCA patients, the BRCA1, we remove ovaries a little bit earlier. So if you remove your ovaries prior to age 35, that's reducing the hormones your breasts are seeing. It's about a 74% risk reduction in getting breast cancer. If you wait a little bit and remove your ovaries by age 40, it's about a 50% risk reduction. So it's kind of like super tamoxifen because you're limiting all the hormones your breasts are seeing. You can still take hormones after having the ovaries removed for those, even the BRCA positive patients. What we don't want to do is patients getting all the exogenous hormones after menopause for no reason. I think that's inappropriate. And if you are taking the combination, and it's combination, it's not just the estrogen alone, but the combination hormones are the ones that increase your risk. Just know why you're taking them. And again, every couple of years, try to get on a lower dose or get off of them if possible. Other lifestyle modifications, hopefully you are doing, hopefully I am doing, hopefully you are doing all of these things because this is just how do you be healthy. So it's great too that it lowers breast cancer risk. So exercising half an hour a day, 5 days a week, a low fat diet. So the beef, chicken, pork all have some hormones in it. Uh, Doing the fish and vegetables lowers risk of getting breast cancer, maintaining the ideal body weight, not smoking. Sorry for all the residents, limiting alcohol. So, and it's even the stuff in college or binge drinking. For women, it's less than 2.5. Some would say less than 5 drinks a week. But the more alcohol you're having, the higher risk of getting a breast cancer or even a recurrence.
I want to say my picture is right here. I love lifting weights, so that's
Does
me right there.
you have a really long left arm.
I do. I do have a lot.
Super. Limiting stress, good luck. I mean, we're all in stressful
Yes.
jobs, but trying to do that self-help and self-health. So taking time out for yourself and getting enough sleep. That's another one as residents. I mean, things
Yeah.
have changed for the better, I think, for getting sleep, but then don't take the extra time off to go party and go do other fun things. Make sure you're getting rest as well. And then choose your parents wisely. That's the most important thing.
Mhm.
Obviously, we
Yeah.
can't do that, but you can do all of these healthy things. If you have a genetic mutation, you still can't necessarily overcome the genes. Medication. So when we talk about what I try to talk about for patients, identifying the risk, identifying how we're going to change screening, identifying ways that you can change your life, so lifestyle modifications. And then if you're still nervous, if you still have this really big high risk, we've got some other medications, but these have more side effects with it. So tamoxifen, most of us know about. Raloxifene for postmenopausal women, or the aromatase inhibitors. Exemestane is the one we think of. The tamoxifen has and raloxifene have about a 50% risk reduction. Raloxifene is not as good for the DCIS prevention. Exemestane and the other aromatase inhibitors have about a 65% risk reduction, but have more of the bone loss and some other side effects. So just knowing your patient and their goals. Honestly, you guys probably aren't going to prescribe these medications if you're in Columbus. If you're in Montana, if you're in maybe Athens, kind of rural area outside of Athens,
Yeah.
North Dakota, you just don't have the access to care, you guys might be prescribing it. So I think it's healthy for you guys to understand these medications. If you live in a place like Columbus, Cleveland, Cincinnati, New York, you have so many different providers, you're probably not going to prescribe these because you have to understand the side effects. Another thing is there's a baby tamoxifen, so baby TAM now, instead of the 20 milligrams, you can do a 5 milligram for certain people. So a lot of different ways we can help reduce risk. The biggest way we can reduce risk has the most changes to your body image, has more risks. Surgery is one way. We talked a little bit about removing ovaries can reduce your breast cancer risk. Removing your breast also obviously reduces breast cancer risk. Nothing in this world's perfect. So if you have someone that comes in, they still have their ovaries intact, they're at high risk for breast cancer. If we remove their breast, it's about a 90% risk reduction. If they've already had their ovaries removed, so again, super tamoxifen, and then we remove their breast, it's probably up to a 96% risk reduction. Again, never perfect, but there's a lot more side effects. When we do breast surgery, this is what we do. This is our job. Different ways we talk about reconstruction or no reconstruction. So one of the things we do is an aesthetic flat closure, where if we're taking the breast and they don't want reconstruction, we're trying to thin out the extra side tissue, thin out some of the tissue in the middle. So that's something that not everyone does in Columbus, not everyone does in the world for sure. And in the old days, as surgeons, it's like, oh, I cured you, I cut off your breast. Sorry that everything looks terrible and it
Yeah.
hurts. And so we're trying to be better and better about that as breast surgeons. So I think you have to make sure who are you sending them to, but understanding there's different ways then to reconstruct the breast. Old days for implants, we used to go behind the pectoralis muscle and they'd release the pec muscle and then put an acellular dermal matrix in there. And so you might lose a little bit of that pec strength. Now we're often putting the implant outside of the pectoralis muscle. There should not be all that breast tissue if we do breast surgery, but again, for just increasing breast size, the augmentation, you have the breast tissue. Again, typically they're putting the implant outside the muscle. You can use your own body tissue. We used to talk about this tram flap. Haven't seen one in 15 years. You probably never saw one,
I've
did you?
never seen
Yeah,
one. Yeah.
right. I'm old. Been around for a while, but we used to take the blood supply was in that rectus muscle and then take the whole rectus muscle and put it up there with the skin and fat of the belly, but we needed that blood supply. Now what we do is a deep flap, and there's only two groups in Columbus. One's at Ohio State, one's called Midwest Breast. And they do the reconstruction all the way up from Toledo down to almost Cincinnati. So really the whole central part of Ohio, they're doing these deep flaps and they're getting the blood vessels and then plugging it into a new blood vessel and then taking that skin and fat along to make the new breast. So again, different ways that we can do reconstruction. The goal for me, patients are or they are not at high risk. I want to identify the people at high risk so that they understand it, so that we understand it, so we can do things differently to prevent cancer would be great. We're not going to prevent it in everyone, so we want early detection. Hopefully, then they need fewer therapies and have fewer side effects because everything we do in medicine has side effects, whether you're giving an aspirin or we're giving an anti-estrogen medicine or we're doing surgery, there's always side effects. By limiting getting the diagnosis, we limit the treatment side effects. That's all I have. Anything else?
Good job. No, that's great. That's lots of good information right there. I think it's going to be very valuable to go through this video maybe once or twice before you actually come on a rotation. I don't know about you, but I just have so many patients on my schedule. And when you come to us on a rotation, I'm showing you the images before we walk into the patient's room, comparing the images. We're showing the images to the patients and coming back and dictating. And, if you don't dictate, you kind of get behind on things. So if you already know this information, I think we can have meaningful conversations as we're seeing patients.
And learning how to do exams, I think that's the other thing
Yeah.
that you all want to know because everybody has lumpy, bumpy breasts. Breast exam is hard. What are you feeling for? If you're doing a breast exam on a person for the first time, you have no idea what their normal is. So identifying what's a normal, lumpy, bumpy, fibrocystic breast versus an abnormal lump. So that's something hopefully you'll get by rotating with us. And then also a little bit, how do you do an exam or follow someone who's already had breast surgery? So that's another challenge. But really out in the real world, you need to know the risk factors, how to identify it, how to do a good exam, and then what you're supposed to do as far as imaging, because you guys are the only ones these people are seeing. And if you don't know what to do and don't get them into the high risk clinic or order the appropriate imaging, they could be missing out on that early diagnosis. So you guys are really our hands and feet in the world when you go out there. So thank you for joining us. Thank you for listening to this. Hopefully you have a great rotation and learn a lot that you'll carry with you your whole life.
We look forward to seeing you.
See you in a
Bye-bye.
bit. Bye-bye.